See, this interpretation of IQC and interpretation of EQAS is very important. And this is the requirement of standard also. As per your clause 7.3.7, in this new standard, previously it was requirement of clause 5.6 in 2012. Now in 2022, it is the requirement of clause 7.3.7. And why you're running a IQC at all? What is the purpose of running IQC? Yes. Yes, Dr. Sangeeta Sharma. Or Alfie George.
Yes, sir. Good
Why
afternoon, sir.
are we running IQC in our lab? What is the purpose of running IQC?
Sir, to ensure the consistency of our analytical process, day-to-day testing process,
Right.
as well as to ensure that our test results are reliable to be released for used for patient.
Yes, very good. See, whatever can happen to our patient sample in our analytical system, when we are running IQC, first that should happen to our IQC and we take appropriate action. We can take appropriate action if, and we can rectify the problem so that same thing is not happening to our patient sample, right? So this is the purpose of running IQC. With the IQC, we get precision. Variation is within the acceptable limit, whatever acceptability criteria we have derived. So what is the conclusion? We want to detect clinically significant error in our system so that our reports are good. And if there is any error, we can take appropriate action after root cause analysis. What we want to do, we want to provide best services to our customers. Problem is when we are running quality control. If suppose quality control is failed, now what to do? One thing is find out there is a failure, take appropriate measure, fix it as early as possible. Or you are saying, I don't know what to do. Only thing I can do, I can repeat the control till I get the right answer. That is not the solution. Because one thing is, you are saying whatever it is the requirement of standard. I have to run quality control and I have followed the guidelines. I am running controls, but you're not bothered about the result of that control. You are, after running control, testing patient sample. Or you are running the control till you are getting the correct result. That is also not the solution. What you have to do, you have to stop testing, you have to investigate, and you have to take the appropriate action. And it is important to change these bad habits. You are repeating the control, or you are recalibrating and then running the control without proper analysis, or you are saying, I will run a new control. If this control batch is not giving me correct result, that means there is something wrong with the control. I will test with the new control. No. Identify. First, there is non-conformance, some non-acceptability of result. Do the root cause analysis, document these things, take appropriate action, and again document that action. And important thing is when you are, because what we are saying, we have to develop good control over the quality of result. Sometimes what happens, problem is not related to our analytical part. Problem is related to our pre-examination part. Some sample is not received in a correct manner. Tube is either overfilled or underfilled, or some clot is there in the EDTA sample or citrate sample. So these are not acceptable samples. Or clinicians, they are using very fine needle to collect the sample. In the process, the samples are getting hemolyzed. Any such thing shall be communicated to the clinician, or if a patient collected sample, to the patient. With IQC, what we get? Precision. With EQAS, what we get? Accuracy. What is precision? How close our results are to each other. What is accuracy? How close our result is to true value. To get the information how close our results are to each other, we have to analyze multiple times the same sample. EQAS sample we are running only once, so that will not give us precision. But EQAS has target value, whether our results are close to target value or not. So with that, we get the idea about accuracy. How many controls to be analyzed? How frequently these shall be assayed? That depends on our workload and distribution of workload. If someone is running laboratory 24 hours, so they have to distribute their controls over 24 hours. If it is open for a limited time, so then what is your analysis time? Depending on that, you have to divide your controls. How these control results are evaluated. One thing is you are preparing LJ charts and you are following Westgard rules, or you are using Six Sigma. So today we will discuss this LJ part. Six Sigma is a big topic that we will discuss in a separate lecture. In internal quality control management, what is required? This is the requirement of clause 7.3.7.2 as per new standard ISO 15189-2022. And now NFBL has decided they will start accepting application as per this new standard from 1st July 2023. But they will keep on accepting application as per old standard also till December 31st, 2023. From 1st January 2024, they will accept application only as per new standard. And this old standard will no longer remain valid after 31st December 2025. From 1st January 2026, only new standard will be valid. And they will not receive any application as per old standard from 1st January. So that whatever application, whatever certificate they are issuing till 31st December 2023, that certificate validity will expire on 31st December 2025, so that there is no confusion. In IQC management, what is required? We require documented procedure. How we will run the control, how many controls, how frequently. Then whatever data we are generating, that shall be evaluated carefully, so that whenever there is any outlier that is detected and corrective action is taken after root cause analysis, then monitor your corrective action for its effectiveness. This is how IQC is managed. Metrics should be similar to patient sample. So as I said, I'm emphasizing upon in this point, you shall have documented procedure. Then what they said, it shall be implemented and review data. So for that, what is required? You have to prepare LJ chart. You have to follow Westgard rules. In hematology, stability of the controls is very less. So what we do, we compare CV% over a period of time. Because if there is a change in lot, you cannot use the mean and SD of the previous lot for the new lot. So then we compare CV%. Variation should not be significantly different with the change in lot. And an additional, this is not substitute of running control. This is an additional thing which you can do to check the quality of your system. Bull testing algorithm. Bull is the name of the person who developed this system. And this is applicable in your hematology. They said, or he said, you are running patient samples, hemoglobin, TLC, RBC, platelet, these quantitative parameters, their average should not vary significantly over time. What you can do when you're buying a new machine, after running 500 samples, take the average of those 500 values. Then after every 20 samples or every day, you calculate the average value of this hemoglobin, of this TLC, of this RBC, of this platelet. There should not be significant difference in the average value of hemoglobin, TLC, RBC, and platelet. If they are moving in one direction, you are finding trend, that means there is something wrong. Only thing you have to consider, on a particular day, there is no special clinic, any anemia clinic where you are getting low hemoglobin, or leukemia clinic where you are getting abnormal values of hemoglobin, TLC, platelet, etc. Any such clinic should not be there. Otherwise, this value will remain more or less constant. This is what people have observed over a time. Sample stability is very important within day and between day. What is this Levy-Jennings chart? In this, we draw two lines perpendicular to each other, one vertical line and one horizontal line. On this vertical line, we write mean value at the point of intersection, and at this mean value point of intersection, and above this 1ST, 2ST, 3ST, and below this minus 1ST, minus 2ST, minus 3ST. On horizontal line, we write number of observations. If you are running one level control once a day, 1, 2, 3, 4, 5, 6, like this. If you are running one level control twice a day, one morning, one evening, two morning, two evening, three morning, three evening, like that. Vertical line, suppose mean value for glucose is 100 and standard deviation 2. At the point of intersection, you will write mean and above this, at the point of intersection, you will write 100. Above this, 102, 104, 106. Below this, 98, 96, and 94. For different analytes, you need to prepare different LJ charts. For different level of control of the same analyte, you need to prepare different LJ charts. Same analyte, same level of control, if you're running more frequently, then same LJ chart will work. Now suppose today, the result is 101. You are putting a point at 101. Next day, suppose it is 100.5, 100.5, then 99.5, 100, 102, 101, 99. So you are putting these points, and when these points are joined, you get a chart like this. this third figure. This is called Levy-Jennings chart. In medical laboratory, these are called Levy-Jennings chart. In all other industries, these are called QC charts or Sheva charts because medical use was described by Dr. Levy-Jennings. Now see, you have a chart, but you don't know how you will accept the result. Suppose you are getting a value 106 for glucose today, whether this is acceptable or not. You have to develop acceptability criteria. What he said? He said, Dr. James Westgard, suppose one value is beyond 3 standard deviation. Look at this lower value. If one value is beyond 3 standard deviation, it is highly different from the rest of the values. Suppose daily we were getting values close to mean, and suddenly on one day we are getting value, say, same example, 100 mean, 2 standard deviation. Suppose the value is either 93 or 108 or 107. These are significantly away from the mean. If control is showing so much variation, same variation is possible in our laboratory results also. Stop testing, do the root cause analysis, take appropriate action, run control again. When this control result is within acceptable limit, only then run patient sample. And don't use this rejected value. This is only guiding you. There is some problem. Take appropriate action. Don't use this rejected value in the calculation of your monthly mean and SD. Otherwise, what will happen? It will widen your standard deviation. And next month, you may accept some value which should have been rejected. This requires some action. Now, suppose one value beyond 2 standard deviation, but less than 3. This is warning signal. For once, you can accept this. But check all things. What are the possible causes of variation? If you're not finding anything, be careful in the next cycle. Suppose it is again showing more than 2 standard deviation. That means something has happened, which has started affecting your multiple results. This is a systematic problem. This is not random. It suddenly happened. It is affecting your 2 consecutive results. Stop testing. Do the root cause analysis. Take appropriate action. When this is within acceptable limit, only then run patient sample and reject both values in the calculation of monthly mean and SD. Otherwise, again, your SD will be wider. Next month, you may accept some value which should have been rejected. Then R4S, random value showing more than 1 standard deviation variation. So what is the reason? Today, why we are getting so much variation? What has happened? Don't accept this. Do the root cause analysis and take appropriate action. If suppose 4 consecutive values are on one side of the mean, beyond 1 standard deviation, again it is systematic error. Find out what is the reason. Is there some change? Or 10 consecutive values on one side of the mean? What is the reason? And the most common reason, when the 10 consecutive values are one side of the mean and within 1 standard deviation, most common reason is laboratory is not calculating their own mean. They are using manufacturer mean, and when they reconstituted, they analyzed, they are finding some variation in the result, and variation is same, so they are finding values on one side of the mean. So what is required? Whatever is the situation. Stop testing. Most of the time, what people do, this out of control situation, they say, recalibration is required. But what will happen? It may create some additional problem. You have to do the proper root cause analysis and then take appropriate action. What is important? Understand the problem. This is random error or systematic error. For this, review the Levy-Jennings chart and see what type of error it is. Do the root cause analysis, take appropriate action, corrective action, and document these things. First, you are identifying this is an out of control situation, and examine this Levy-Jennings chart. What all rules you want to apply those rules, because for understanding any, for taking action on any problem, first thing is you understand the problem. First thing is there is some problem and what is the nature of the problem. But when you are applying Westgard rules, when you're taking action, important thing is you have to understand what is the situation, whether some action is required or not. If suppose 1 to a situation, one value is slightly out of this 2s limit, but within 3s, and you're rejecting the run, this is false rejection, unnecessary wastage of resources. If one value is beyond 3 standard deviation, random value showing more than 4 standard deviation variation, these are random errors. You are analyzing your system and then you're not finding anything, you are running control again, you're finding result within acceptable limit, this is random error. But if it is affecting your multiple results, it is systematic error. What is the reason? You have to take appropriate measure after root cause analysis. So now what is required? You review Levy-Jennings chart. Some unpredictable random error or systemic change in mean. This may be gradual trend, this may be abrupt shift. If values are moving in one direction or with a change in reagents, suddenly results are shifted to lower or higher side. So you have to see whether it is gradual trend or abrupt shift. Then you have to take action accordingly. I am muting only once, only for a second. Now see this, R4S variation. This is not an acceptable situation. And what is trend? Look at this. These red dots, values are increasing in one direction. This is called trend. This may be because of some deterioration of the reagent or some leakage in the tube or some blockage in the tube, or maybe related to some problem with the light source or some other problem that we see. And in shift, what happens? See this lowest figure. The values are low and then these are maintained in the lower values. This is called shift. This. In this systemic errors, if there is a shift, what may be the reason? There is change in the lot of the reagent, or there may be change in the calibration, or you have reconstituted, that is causing some problem, or maybe related to instrument, some preventive maintenance has been performed, lamp has been recalibrated, or some temperature issue or some water quality issue. These are the reasons for the shift. What are the reasons for the trend? Again, there it was change, either lot or reconstitution or calibration. But in trend, if suppose reagents are not stored properly, with time, you may start getting values going down. That may be because of deterioration of the reagent or deterioration of the control. Or reagent is not stable, or maybe some calibration shift. A random error may occur. Suppose there is some bubble either in the reagent or while pipetting the sample, either pipetting the reagent or pipetting the sample. This may cause some fluctuation in the value, or it is not mixed properly, or some fluctuation in the temperature or electric fluctuation. These things can cause some random error or some random blockage in the tube. After one sample analysis, then that block washed away, which is causing a random error. But what is important? Lab shall have effective troubleshooting procedure in place. You have to carry out root cause analysis, you have to take appropriate action, document this, but make only one change at a time and monitor that change for its effectiveness. Otherwise, what may happen? A wrong report may be released. There is a risk of issuing wrong report. If you're taking appropriate action, this is risk management. And in this new standard, it is talking a lot about risk management, and two clauses, 5.6 and 8.5, these are dedicated to this risk management. And how to decide whether any action is required or not. If there is some non-conformance, whether it will result in incorrect result or not. Sometimes, suppose your SD is very tight, there is out of control situation, but it is not causing significant variation in the patient result. Whether a action is required or not. So these things we learn with practice, with the good knowledge of our subject. So what is important? We have to develop a very good knowledge of subject, very good knowledge, how to apply knowledge of QC in a practical situation. An important thing is, suppose there is one QC failure every 10 to 12 months. It is not indicating any systemic problem, something not very serious. But if it is happening more frequently, maybe twice in a week or every week, every time you are facing the same problem, so you have to see why it is happening again and again. Other laboratories are not facing these type of problem. So do proper root cause analysis and take appropriate action. Again, what is important? Documentation, documentation, documentation. Because with documentation, you will come to know this is happening frequently. Wherever there is any out of control situation. First see, has anything changed? And where is the change? Whether we have started a new reagent or started a new lot of control, or we have recently calibrated with a new calibrator, or some recent maintenance has been performed on the machine, or some part replacement, or maybe some new operator. These may be the reason. Or if suppose more than one chemistry affected, whether these tests are similar or dissimilar, all enzymes or one enzyme, one endpoint, whether their filter is same, these are assayed on the same filter, or single or multiple level of control affected. Suppose two parameters are showing problem, the normal level control, but not with higher level control. One situation is this, or one analyte is affected with normal level as well as high, or all three levels are affected. So that way you have to see. Or problem is with the main machine or backup machine, or some change in some problem with the environment, deionized water system, some temperature, or reagent shipment or storage problem. So that is affecting your multiple parameters, or change in deionized water, that is affecting your multiple parameters, or temperature change, because these things will affect your all results. So what is the reason? And if you're finding any error message in your machine, see from the manual. And QC target range, sometimes what happens, we use old package insert for the new lot, and we are facing some problem. This is not within the acceptability limit. Or whatever we are getting, what is the status with other laboratory people who are using the same machine, same type of reagent? See, calibration is okay or not? Or manufacturer has changed some instructions recently, which laboratory is not following. See, first thing is you analyze very carefully. You have to develop a little bit Sherlock Holmes within you to analyze the situation. See, when you have out of control situation, see, if there is anything related to control, new lot of control, reconstitution of control, or storage of controls, a liquid preparation is proper. If you're not finding anything with the control, check the reagent. New lot of reagent reconstitution, storage of reagent. If there is no such situation, check the calibrator. No problem, check instrument hardware. No problem, check the environment. There is no problem, check the operator. Who is operating the machine? So this is how you have to proceed in case of control, whether it is correct material, it is not expired, it is stored properly, it is reconstituted properly, and you are running it promptly after bringing it to room temperature. If suppose there is some evaporation, so this will become little more concentrated, it will give you higher values. The reagents, correct reagent, these are kept at correct position in the machine. It is not like that. In the place of cholesterol, somebody has put that glucose reagent. It is not new lot. It is stored properly, prepared properly. It is not expired. It is not a new lot. Similarly for calibrator, there is no new calibrator lot, prepared properly, stored. For certain things are common in all these. It is not expired, correct calibration, disk loaded, within lot calibration managed correctly, instrument hardware, proper maintenance, daily, weekly. Visual inspection is not showing any problem, any leak or some buildup in some protein material is deposited or syringes or these cuvettes. So there are no scratches on the cuvette. Monitor is not showing any problem. Diana is water system performing correctly, proper maintenance. You are checking temperature, humidity, temperature, resistivity, etc. And air quality is adequate. If you are checking all these things, you're not finding any problem. There is single out of control situation. And you are repeating the control, it is acceptable, within acceptable limit, then it may be random error. You have checked everything, you are not finding anything, and on repeat analysis, it is okay, random error. Then no corrective action is required. But if it is happening frequently, then you have to extend your root cause analysis. You have to call company people, discuss with them what is the reason why I am finding this random error so frequently. Now, after running QC, problem is solved, you have documented, you review patient results which were released between correct QC and QC failure. Repeat testing if it is required, and clinician shall be informed about that. So that way you have to proceed in your IQC, and you have to be very careful when you are running IQC. In hematology, stability of the control is less. These days, some machines, they are providing stability, and this controls with long stability, but most of the time, what happens, stability is less. So it is not possible to analyze by LJ charts. And whatever your machine is providing you, that is not LJ chart, that is comparison chart. With mean value, manufacturer mean value, they are providing you upper level of comparator and lower level of comparator. Your results are between this. So that is not Levy-Jennings chart. Levy-Jennings chart by definition are prepared by mean and ST. So for that, for different lot, you can calculate CV%. So this CV% should not fluctuate significantly. And when you are calculating CV% for DLC, use absolute values, not percentage. Don't calculate percentage of the percentage. It will give you unpredictable results. Calculate this variation in your neutrophil, lymphocyte, monocyte, eosinophil, etc. based on absolute values. These machines are providing you absolute values also. This is related to our IQC. For EQAS, what is required? Z score. For quantitative EQAS and comparison with peer group or whatever evaluation criteria, these EQAS providers are providing you for qualitative results. See, for qualitative result, if it is, say, for sputum for AFP, they may say, based on analysis of participant results, 85% participants were showing sputum for AFB positive. If suppose 15% are saying it is negative, then their evaluation is not correct. To make a qualitative EQAS more effective, there should be consistency in more than 95. Their consistency should be of more than 75%. In quantitative, we use Z score. It is provided to you by the EQAS provider. And this is this you can read from the standard. Just for the completion's sake, I have mentioned this in the presentation. So you shall have procedure as we discussed for IQC and EQAS. Here you shall have a procedure, and you have to follow the procedure. You have to detect trend and shift. You know what is trend now, and you know what is shift. And we discussed statistics in our last lecture. So for IQC, we discussed all these points. We shall have a procedure and acceptability criteria and how we will analyze. And we also said, make one change at a time. So whenever you are changing this lot, that applies here also. There shall not be change in the lot of reagent, calibrator and control on the same day. Third party IQC material should be considered. But if it is not available, then you can use whatever company people they are providing you, whatever is available. And when appropriate IQC material is not available for some time, as I said, you can use patient sample or moving average of patient result. We discussed. So this I included for your reference. So this you can read from the ISO 15189-2022. So right now we are not discussing because many of you are following new standard. Many of you have attended program based on new standard, but still following old standard. Many of you have not attended. So whenever you will attend, so you will know all these things. But I have included this. Now this after few months, this new standard will be applicable. Important thing is, the rest of the things are same. Important thing is when you're selecting a EQAS provider, you have to see how they are offering you target value. They provide one group mean, that is target value. So whether they are providing you a group mean or they have selected few reference lab, they are taking mean of that, or that is set by a panel of expert, or they are using some reference material. This is calibrator, whatever value it is showing, your result should be comparable to it. So now it is the requirement of the standard. You have to follow 17043 accredited program and how they are deriving this target value. If this EQAS program is not available, so either you are exchanging sample with other laboratories or you are carrying out split testing. This EQAS data, one thing is this EQAS sample shall not receive any special treatment. Whatever treatment you are providing to patient sample, same treatment shall be given to EQAS sample. It should be analyzed by the same person who is analyzing patient result. These results shall not be discussed with your peer group till the last date of submission of result, and this sample shall not be referred to a referral laboratory. You have to develop in your lab only these data. Only then you will be able to see whether the variation is within acceptable limit or you need some action. How the Z score is evaluated. If it is -2 to +2, this is within acceptable limit. If it is 2 to 3 or -2 to -3, it is warning signal. If it is more than 3 or less than -3, it is action signal. This Z score is provided to you by your machines, by your EQAS provider. One action signal or two consecutive warning signals indicates intervention. How is it this Z score is calculated? It is lab result minus assigned value divided by standard deviation. It is not the standard deviation which you get in your IQC. It is the standard deviation which EQAS provider is providing you. And what is the importance? See, if you are getting Z score 4, it is not acceptable. More than 3 is not acceptable. Suppose your result is 108. Assigned value is 100. Standard deviation 2. 108 minus 100 divided by 2, it is 4. This is not acceptable. And after analysis of EQAS sample, preserve this EQAS sample after making aliquots in deep refrigeration. When this is out of range, do the root cause analysis. Whatever need to be checked, check all those things. IQC results on that date, quality of water on that day, temperature, who was the operator, how this sample was reconstituted. You're checking all these things, develop format for that. If you're not finding anything, run a aliquot again. Now suppose the result is 102. 102 minus 100 divided by 2, 2 divided by 2, 1. Now the Z score recalculated is 1. It is within acceptable limit. Probably it was random error in your EQAS. But suppose again it is showing close to 4. That means problem is still there. Now you are sending a portion of sample to a referral lab. Previously it was not allowed before the submission of the result. But now you have the result. That laboratory, your referral laboratory is saying, suppose it is 102. And in your laboratory, again it was 108. So that means some problem is there with your analytical system. You have to call company people. But suppose that laboratory is also saying it is close to 108. That means there is no problem in the analytical system. Some problem is related to that particular sample. Either maybe reconstitution in your lab or some problem with the transportation of EQAS sample. If you're asking EQAS provider, they are saying, okay, we have received this problem from many other laboratories also in relation to this analyte, so don't accept these values, we will issue you a letter. Then you know the problem was with the sample. Otherwise, some problem is there related to reconstitution. You have to analyze who has reconstituted, how the person has reconstituted, how the person has mixed. So you have to check. So that way you have to proceed in a systemic manner. Sometimes people say, I'm not working in an accredited lab, so I don't need any QC. People who are running, because as we discussed, this is a requirement of the standard, clause 7.3.7. When my lab is not accredited, 45189 is not for me. See, but a correct report is your requirement. If QC is showing problem, that means same problem can happen to a patient result, whether you are going for accreditation or not, but it is a good practice to run QC. This is not the answer, it is too expensive. You have to find out the solution. Quality always comes at a cost. So with QC, you get information about the system, whether your analytical part is correct or not. If there is some problem, take appropriate action. Select good vendor and you shall have good control stability. Store these properly with proper guidelines at proper temperature, whether in deep freezer, and prepare aliquots correctly. This Eppendorf tube should not be too large. If suppose in 1 ml Eppendorf tube, you are storing 0.5 ml, that is not correct. And when you're bringing that to room temperature, don't keep that open. Prepare small aliquots and avoid repeated thawing and freezing. Take out one aliquot from the box and bring that to room temperature rather than bringing the whole box outside. And train your staff how to use, how to prepare the aliquots, how to bring that to room temperature before processing, and how to note down the reading and prepare the Levy-Jennings chart, analyze the Levy-Jennings chart, how to take the decision. People who have to analyze, they should know how to analyze. People who have to take action, they should know how to take action. And whatever target value they are prescribing you, use proper comparison sheet. It is not like that if someone is using a sheet of old lot, a sheet of old lot with the new lot, then you may get some confusion. See, this quality management system, a procedure, gives confidence to lab on their performance and reliability of reports. It is useful for laboratories seeking accreditation and also useful for laboratories who are performing patient samples. You can improve. How? By careful interpretation of existing control data. You can add some more rules, some more system of analysis, and you are properly following the guidelines, right?